Welcome to Always Prepared, ensuring your hospital at home program is ready for any emergency, large or small, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine. We'd like to recognize the generous support of the John A. Hartford Foundation for the Users Group and for this webinar series. It's now my pleasure to introduce our moderator for today's webinar, Dr. Linda DeCherry, a member of the Hospital at Home Users Group leadership team and a national expert on hospital at home programs. Dr. DeCherry is the Vice President of Clinical Strategy and Implementation at Medically Home, where every day she helps sites around the country implement virtual hospital programs. Previously, she was at Mount Sinai Health System for almost 2 decades and was the clinical director of Mount Sinai at Home, its home-based service line. We're so pleased that Dr. DeCherry is here with us today to moderate this webinar. Dr. DeCherry, please take it away.
Thank you so much. So I just wanted to make everyone aware of the Hospital at Home, our website, our Twitter handle, and most importantly, our Technical Assistance Center. We have recently refreshed the Research Center on that website, so please go look at it. We really have a lot of the most recent articles nicely cataloged in different buckets on the website, and I think it's really useful for everyone to be able to find things much more easily. So I want to welcome you now to our 18th webinar. We have hosted these over the last couple years that to be able to bring really important issues to the forefront and discuss important topics for our membership. On the website, you can see our full list of webinars, and you can access all of the slides and the previous recordings. I would like to alert you to one thing of research that's going to be coming up pretty soon. A team of researchers at the Icahn School of Medicine at Mount Sinai are going to be looking to interview people about their experiences taking care of a loved one during a hospital at home stay. And also separately, they're going to be interviewing hospital at home user group program leaders about their input on caregiver experience and their expertise. So this hopefully will be approved in the coming weeks, and we're going to be sending out some messages about this research. Another announcement is our annual meeting. It is October 12th. It is a virtual meeting. October 12th virtual meeting, but it is a pre-conference to an in-person HCM annual meeting in Seattle, Washington, which is October 12th through 14th. And in the HCM meeting, there's going to be a hospital at home track of sessions. So basically you can make a full experience of a virtual day and then follow the track at the in-person conference. So we've now called that the Hospital at Home Palooza, because it's going to be a whole series of events over those couple days. And so now we're going to get to the main feature of today, which is our webinar today, Always Prepared, ensuring your hospital at home program is ready for any emergency, large or small. And we have 5 speakers today. Here are 3 on one side and 2 on the next slide. I'm going to go through them all. So we're first going to be joined by Dr. Scott Harrison, who is the Regional Chief Medical Officer at Appalachian Regional Health in the Kentucky River region. He has over 20 years of clinical and leadership experience in hospital medicine and emergency medicine. Next, we have Sarah Kelly. She's the Ambulatory Emergency Preparedness Manager with the Mass General Brigham Department of Emergency Preparedness and Business Continuity. Sarah focuses on healthcare emergency preparedness and response for non-hospital spaces, including ambulatory sites and home-based care. Next, we have Dr. Kevin Whitley, who's the Chief Operations Officer and Chief Nursing Officer for the Healthcare at Home program at Mass General Brigham. Dr. Whitney has the clinical and operational responsibility for traditional MGB home care and implementing the MGB home hospital service through the CMS waiver program. And our last 2 speakers, we have Vanessa Boyle, who's the operations manager for Advanced Care at Home Command Center for Mayo Clinic, Florida. In this role, Vanessa leverages technology to drive operational efficiency, scale the virtual home hospital platform, and connect next generation digital pathways. And last, we have Dr. Michael Maniaci, who is the Enterprise Medical Director of Virtual Care in the Mayo Clinic Center for Digital Health, the Enterprise Physician Lead for the Advanced Care at Home program, and the current Medical Director of Mayo Clinic Hospital in Florida. So now I'm going to explain a little bit about how we're going to run today's webinar. We're going to have each of the three sites spend about a minute or two just giving program introductions. And then we're going to go to a number of prepared questions that I have, and each site will answer, some of them 2 sites, some of them 3 sites will answer each question as we go along here. And then at the end, we're of course going to have time for audience questions as well. So I will start by inviting Appalachian Regional Healthcare to tell a little bit about their program.
So yeah, thank you again for having me. Joined ARH in February of 2022, and as I mentioned, came in at the tail end of the process that had been initiated long before I started, but having go through the CMS waiver, we have successfully just gone through our 50th patient. So we are still new in the game, learned a lot and still continuing to learn a lot as we go. So this is extremely helpful. So I'm thankful to be here. Looking forward to it.
Excellent. Thank you. And now, I don't know if it's Kevin, are you going to speak for Mass General Brigham here?
Yes.
Perfect.
Yes. Great. So good afternoon, everyone. Just a little bit about our program. So the Mass General Brigham Home Hospital Program actually was formed based on the foundation of 2 individual programs at our 2 AMCs at Mass General, as well as at Brigham and Women's. And we first actually started the Home Hospital Program back in 2016, and of course went through the waiver program a couple years later. But I would say over the last 6 months to 8 months in particular, our strategic initiative is to really form this home hospital program as a Mass General Brigham service line home hospital program. And we're now we've created a capacity of about 30 patients, and we're averaging an average daily census in the high 20s.
Thank you. I don't know, Mike or Vanessa?
Yeah, it'll be me.
Mayo? Great.
Hello, everybody. Glad to have you all here. Mike Maniaci. At Mayo Clinic, we began our hospital at home program called Advanced Care at Home in July of 2020. We opened a central command center in Jacksonville, Florida, and started treating patients in Florida that July. We then expanded our range to cover patients at one of our Mayo Clinic Health System sites in Eau Claire, Wisconsin, from the same command center virtually with the supply chain there in Wisconsin. Then about a year later, started treating hospital home patients in Phoenix, Arizona, using the same command center in Florida. So 1 command center, 3 different sites for our pure home hospital program, which we've seen about 2,200 patients over the last almost 3 years now. We also have a program called Care Hotel, which is a post-surgical discharge observation type program in an outpatient basis on hotel campuses. That encompasses the 3 campuses I've already talked about, as well as Rochester and another site in Southeast Minnesota. So with that program, we've seen about 2,800 patients virtually as well. Our average daily census runs about 18 to 21 hospital level patients and about 6 to 8 post-acute surgical patients, for about a total of about 30 a day at that command center.
Excellent. So our first question is, suppose there is a power outage in a neighborhood, one street, a couple houses, or small neighborhood where you're serving patients. How would you handle this situation? How do you plan for that? How do you handle this situation? And I think we've kind of predetermined who's answering some of these questions. So I think those from MGB, we're going to take this one first.
Hi, everyone. So excited to be here with you all. This is something that we think about all the time. So in order to approach a small scale power outage like this, First, we have to identify the problem. We currently contract with Bioformis Remote Patient Monitoring. This is our patient monitoring platform. We have nurses that monitor the platform 24/7 and will reach out to the patient if the signal is lost. Alternatively, we might identify the problem through the patient contacting us directly. In the future, we hope to set up a technology solution that uses utility provider data so that we can receive alerts down to the individual home level when there's a power outage. But for now, our identification pathways are really through the remote patient monitoring platform and direct contact. Once we've identified that there is a power outage, we want to establish our situational awareness. We want to identify, is this just this one patient's home? Is this the neighborhood level? Is this a regional level issue? We would reach out to the utilities company to get an estimate of how long it might take to restore services, and we would do a needs assessment for the patient. So we would confirm if the patient has a generator at their home. If so, we would make sure that they're using that generator safely. We would ask if they have flashlights or other safety items available. We would inquire about O2 concentrators, battery backup for durable medical equipment, as well as ask if the patient's medications require refrigeration. If needed, we would dispatch our medical, our MIH, our mobile intelligent, or excuse me, our mobile paramedics to assess the patient and home environment to ensure safety. If the care team, including these mobile paramedics, our advanced practice providers and doctors, decide that it is unsafe for the patient to stay in the home, they would then be transported back to the hospital. So that's a high-level overview of how we might approach this situation.
Thank you so much. I think we were going to ask Scott for this question as well. How have you thought about this question?
So kind of building upon that, we also have Bioformis for remote patient monitoring. Should that call come in to say, hey, we've lost contact, we verified, just as kind of mentioned, the checklist of, do we have other options for power? How big a scale is this? I think initially, we would deploy our clinical team to go do, an in-person check, kind of understanding that we don't know how long that power outage is going to last. I think the conversation then becomes with the patient and the caregiver, do you have alternative cellular options? Do we have the ability to just communicate on a regular basis outside of your own, continuous power abilities? And then, not everything requires, true 24-hour feedback. For instance, a lot of the times, if we're just treating an infection with IV antibiotics, do you really have to have that continuous monitoring? That's an assessment that can be made to determine, your options. What's the comfort level of the caregiver and the patient to say, all right, you're just about done with your treatment. You need a couple of days of IV antibiotics. Hopefully this thing is back on in a couple hours. However, should this, go on a little longer, are you able to continue with the plan of care for another day or so if necessary? And if not, sometimes those patients do have to come back. But I think assessing the clinical needs of the patient at that time kind of helps determine course of care at that point as well. Because it's unpredictable. If there's a nasty storm, it may be down a couple of hours, could be down a couple of days. We don't know. But what do we have in our resources to ensure that you can still get the care in your, to your comfort level? And like I said, if it doesn't work out, then we may have to bring them back to the hospital.
Right. Yeah. What I'm really hearing is that both of your health systems, make an assessment, really look at that individual patient and determine if they can stay and not have a reflex that everyone has to come back in that situation, really determining on the clinical situation. That's great. Great. All right. We're going to go to the next question. So how would you handle an emergency situation in which you are concerned that you will not be able to reach your patient's home? So this could be flooding somewhere. This could be a snowstorm that's so large that you couldn't get to your patient's homes. So something like that. I think this question, because this is a pretty important one, we're going to have all three of the sites respond to this. So Kevin and Sarah, we actually had you going first again on this one.
I'll be taking this one as well. So we're in Boston. Our biggest concerns are nor'easters, particularly snowstorms. So if there's a situation, a storm where we're concerned that we're not going to be able to reach our patients' homes, we activate our home hospital severe weather response group. This is a group that we've identified of home hospital leaders that include Kevin as our Chief Operating Officer and Chief Nursing Officer, our Chief Clinical Informatics Officer, as well as our Hospital Capacity Liaison, who is a role within our home hospital team that docks into our larger enterprise capacity management team, and the Director of our Emergency Ambulance Services. This team would come together to do several things. First and foremost, send out notification and communication to our staff with proactive messaging to the care teams, including the details of the event, how to prepare themselves, and how to prepare their patients. At the same time, we would be doing an assessment of our patients. Ideally, this would begin 72 hours in advance for a severe weather event, if that is what we're concerned would be the impact to reaching our patients' homes. At the point of admissions, all of our patients are screened using a severe weather assessment and safety checklist. So it's at this point in time that the patient's homes are actually assessed for access issues and things of that nature. For potential patients, they would undergo the screening, and if there are concerns around access to the patient, or if the patient has potential utility failures, things like that, we may choose to hold admissions if we foresee a major event coming that would impact the ability to reach a patient's homes. For existing patients, if we have the benefit of foresight and can plan ahead of time, we would reassess all of the patients using the same safety assessment to make sure that we can get to the patient's home. And if not, they have access to food, water, other utilities, things without us being able to access them. If it is determined that it's unsafe for the patient to stay in the home, if we're unable to access them, we would then work with 3 of our key leaders to coordinate transport back to the hospital. So this transport coordination is led by the Director of the Ambulance Service, again, the Hospital Capacity Liaison, and the Home Hospital Clinical Director. The considerations in that transport include if the hospital is an appropriate distance to the home, has available bed capacity, and can meet the clinical care needs of the patients. So that's kind of our approach to severe weather planning, which is really the main concern that we have around it being able to reach our patients' homes.
Great, thank you. I think next we're going to turn to Mike and Vanessa. You want to tell us what emergency situation you might have in Florida or one of your areas, and how would you handle that?
Thanks, Dr. DeShera. Yeah. So with Hurricane Nicole, there were significant flood warnings. And so our first step is to work with the safety team and the whole time we're determining whether a weather system is going to impact the Jacksonville area. Safety would notify the Mayo campus, and they would stand up the hospital incident command center. Advanced care at home is included in the HICS structure for storm planning, and we're determining whether or not we need to activate the planned emergency response team or PERT. And for advanced care at home within HICS, we're establishing whether or not how far we need to execute our hurricane plan to determine one, how to care for our patients during the storm, or if we're going to need to relocate the command center because we're expecting significant loss of power or flooding. So there's different levels of our plan depending on the situation and really what the storm calls for. And the key considerations are the proximity to Jacksonville, the duration of the tropical storm or hurricane, and if there's going to be bridge closures, if there's surges or flood warnings and things like that. So in the week leading up to Hurricane Nicole, we determined that the strength was unlikely to increase and that we would not need to relocate our command center to care for patients at other Mayo Clinic sites in Wisconsin and Arizona. We did, though, need to think through how to care for our patients given all the flood warnings. For that, we started to reduce our Florida census within the week leading up to the hurricane by just not admitting patients into advanced care at home and continuing the clinical care for patients that were currently on census in Florida. The physicians and our APPs were clinically evaluating the patient's care needs to determine if they were going to be safe to discharge prior to the storm hitting, or if they would need a special needs shelter, or if they needed to return to campus because they still met inpatient criteria and needed that level of care. So in collaboration with administration, the clinical team was working to know which patients lived over bridges and flood zones and all that. And that's a factor into the evacuation plans for the advanced care at home patients. We wouldn't keep any patients at home if there were any risks of someone not being able to get to them to provide care during the hurricane. So for all the patients in Florida, transport was scheduled for the ones that needed to come back to the brick and mortar. Hurricane Nicole, when it hit Jacksonville, we didn't call PERT. So all of our team members were still able to report onto campus and come in. So we didn't need to have anyone stay overnight. If we did, it's likely we would be relocating the command center in that event. And we basically have an area inland in Georgia where there's less likely to be severe weather and storm surges. So in that case, we would have had go bags and checklists to make sure we had all the tech needs to basically stand up a command center elsewhere and continue to care for patients in Wisconsin and Arizona. So in the event for Hurricane Nicole, PERT wasn't called, our staff came in, and it was just an example when we were caring, we had safely discharged or gotten patients into the brick and mortar, communicating to safety in our hospital leadership to make sure that kind of the patients were where they needed to be throughout the storm. And we really, at Mayo Clinic, we approach our emergency plans with an abundance of caution and make sure to do what's right for the patient and our staff.
Thank you. Yeah, so it's obviously very important. You're thinking both about the patients and your command center, which might have had to have been relocated. Thank you. All right, I think now we're going to turn to Scott.
So as I mentioned earlier, we're a really new program. So a lot of this honestly hadn't been considered until this, I was approached with this and I thought, well, gosh, that's really good timing. So we had they called it a 1,000-year flood in late July of last year. Massive rainfall in a short period of time. I believe I read there were over 600 helicopter rescues and countless swiftwater boat rescues. So we knew that we hadn't planned for this kind of contingency. So we kind of had to react on our feet at the time. I think that, our region, the region that I serve is in Southeast Kentucky. So the phrase over the mountain and through the woods literally applies to our patient population. So it depends, I think, a lot of the emergency situation. Was it flooding? Is it an ice storm that locks the roads down? Is it a rock slide that takes out road access? So I think a lot of that would have to depend on what is my access issue? Is it just because they're on the other side of a creek or river and the bridge is washed away? Or can I not access them at all because nobody's moving into town from an ice storm? But we have agreements with EMS as well that they can, whether it's during, after hours or during regular hours, if they have access from whatever resources they may have, we have an agreement with them to check on the patient as well. And they can assess the need, render care if necessary, transport back if necessary. But, you also, again, the way our population is laid out, maybe you have access to, family that lives close, neighbors that can help. I think, helping out the caregiver and the patient to what degree that we can. So I think a lot of it is situational dependent, but kind of planning ahead for our most likely situations, is something that we're looking at because we had to. Now we need to expand that, the what if scenarios, obviously, and come up with that. But I think having that partnership with that EMS it would be a key for us as well. And then assessing, look at it too, if Amazon can drone a package to my house, maybe I can get some medication or other supplies across, an inaccessible, roadway. So those are the kind of things that we should start to look at. And, fortunately, we're young enough that our daily census would max at 4. So we didn't happen to have anybody in home during that flood, which is grace for us. But, what if, right? So having that communication with EMS, utilizing our local resources from an emergency response, that's kind of how we would approach situational dependent.
Excellent. Yeah, sounds like that partnership with EMS is pretty important. So that's a great thing for everyone to think about. All right, I think we're going to move on to question number 3. I'm going to switch up the order a little bit. So the question is, what do you do in advance to prepare for an emergency? And I think I'm going to start with Mayo this time. So Mike or Vanessa?
Yeah. So to prepare in advance takes a lot of planning, and our disaster plan has to be very thorough. So it's not just the disaster such as a hurricane, but what are the components of that? Because you think hurricane, you think winds, storms, things are taken out for, a short period of time, then passes. But you have to look at, well, what if we lose power? What if we lose power for a week and the patients don't have power, even though the hospital does, the command center does? What if the patients don't? Can they go without that? What if they have power, but there's no internet and that's taken out? What if there is power and internet, but the pharmacy we use as a local supply chain floods? What happens if everybody's okay, but shipments coming into Florida can't make it, so we can't reach our patients that way? We can't resupply our stocks of things. What if everything in Jacksonville's fine, but Miami's hit hard and the governor diverts all the resources down to there? So there's many different situations with one disaster we have to look at. So when we build our protocols, we say, what happens to our patients? But what happens in all these other little contingencies that may pop up, and how do we affect those? And we look at that in Florida, but then we also have to look at any disaster that pops up in any other state and have the same type of contingency plans. Then we have to simulate, okay, this is a disaster of just a category 2 hitting Jacksonville. Let's evacuate, let's move the mobile command center. We practice the scenario, we have go bags, we get going, we move to Georgia. But what happens if that, those people get blocked off by the storm? Who takes over then? What happens if, again, it's one of those power outages for 7 days, and we start to do different types of simulations? And then we start asking our vendors as well, because this is not all Mayo Care, it's Mayo Care through other providers. What do you guys do to step up, and how do you execute on this? And what do you need resource-wise in order to, make sure our patients are taken care of if we get the situations that, we're doing okay at Mayo, but they're not doing okay, or the patients, isolated in their home. So of course, as Vanessa says, you don't want to be in that situation. If you have to move the patients in the hospital or discharge them because they're close enough to discharge, that's the primary aim. But then what do you do with the program on day 3, 5, 7, 10, depending on the impact of the disaster, has to be looked at and be part of your simulation as well.
Excellent. Thank you. Maybe I'll turn to Scott.
Absolutely. So, a lot of it too is to your situational awareness point. How much advanced warning do we have? And what resources can we utilize? We have 14 hospitals in our health system, and how can we leverage them? Some are, it's probably 300 miles geographically between the two farthest points. But how do we use those closest to our proximity to help, maybe offload patients that we can't take at our facility, or if we had to bring them there, or do we have the ability to, maybe stock up the patient's home with supplies if we anticipate several days of, access issues, or, just weather related in general? Are we able to supply the antibiotics? Is the caregiver comfortable enough? So I think those conversations that, if you do get enough warning, and experience is a good teacher as well. So we're going to do things differently now than what we did before. And we're going to have those conversations in advance that, the what if scenarios I mentioned for family, for our own internal training of our staff, and then again leveraging the other sister facilities that we have closest to us. So I think a lot of it has to do with what are you facing? All right, for instance, do you need to anticipate having extra communications? If you lose a landline, so to speak, can you use other forms, whether it be a mobile satellite that helps communications, or using cradle points if you just have connectivity problems, creates that cloud-based, mobile option. So anything that you can kind of do as a contingency, having that, whether you don't, and you hope you never need it, right? But if you had those resources kind of planned out in advance, then you're going to be much better prepared.
Very true. Thank you. And now we'll turn to Sarah and Kevin.
Great. So I was going to take this. As I mentioned earlier, our capacity right now is 30 patients, but our plan is to scale our home hospital program to close to 100 patients by the end of this calendar year. And the ultimate goal is to be around an average daily census of 200 patients. So definitely we wanted to ensure that we have a really comprehensive emergency operations plan for home hospital, especially to be able to scale to that degree. So one of the advantages that we've had is both at Mass General and at Brigham and Women's, both programs initially really fell underneath the emergency operations plan for each one of those core organizations. So they've been able to follow the emergency operations plan that's been in place at each one of those organizations. However, what we've tried to do over the last several months and have really made a lot of progress is we wanted to be really proactive and try to think of what type of event or what details or specific types of events could really occur in the home, in particular to home hospital acute care patients, which might be obviously different or would be different from traditional home care patients. So we assembled a group of clinicians, leaders, frontline staff, and we conducted a hazard vulnerability analysis to really identify what are the top issues that we should really focus in on as we continue to advance our emergency operations plan. And we came up with 7 major themes: security issues, such as the possibility of home security issues, an active shooter. The second was a digital or IS type event, so downtime events or even cyber terrorism that could potentially impact our ability to care in the home. Severe weather, as Sarah talked about earlier, utilities issues. And in fact, we actually did have a recent utility issue. Our team arrived at home and identified a significant gas leak in the patient's home, and they were able to evacuate the patient out of the home and connect with our emergency operations team. Also, fire and environmental health, infection control, and then we grouped the rest under other. So as we build upon the existing plans that we have at each academic medical center, we also have the advantage as we have formed Mass General Brigham Healthcare at Home. And within Healthcare at Home is our Mass General Brigham Home Hospital, but it's also our traditional home care program. And there are existing policies that have been in place for a long time. So leveraging home care plus the AMCs in doing this planning, we had a really good starting point, and we're continuing to refine and just really build in, focusing on those top priority areas of that hazard vulnerability analysis.
Super, super. That's great. And I think that's going to get a little bit into our next question. Question 4. How are your hospital at home program emergency protocols integrated into your mother or sister hospital's emergency protocols? How are they really engaged or complementary to each other? And I think we're going to start with Mayo on this one. So Mike and Vanessa.
Sure, I'll jump in on this one. So yeah, really, again, when disaster planning, we have to look at what are the emergencies that can happen. And because we're separated by geography, what are the different things? So in Arizona, it's dust storms, the big hubbubs that come through and it can take people out. In Wisconsin, snowstorms, tornadoes and other, trees being down and such. And then obviously flooding and hurricanes in Florida. So we have to be prepared for each of these situations and ready for each one. So that's multiple disaster preparedness type of programs, looking at each of these type of things that can happen. Each of the sites have to be trained and simulated on what happens that particular disaster site-wide. So what do the APPs do? What does the supply chain do? But then our command center, secondly, has to know what to do in all these situations, because that command center is overseeing care in all these different places. So how do the virtual nurses, the virtual physicians interact? What do they expect? How do they interact with the protocols? If internet's down here, but power's down in this different state and so on. So you could have multiple disasters at the same time too, which would be a catastrophe, but we're ready for it. But that's command center has to step up and really know what's going on with all these procedures. And then as an enterprise, we have to have redundancy. So not only can we move our command center that's located in Florida to Georgia, but again, if that's taken out, our Wisconsin site has a command hub that can step up and be a command center for several days. It's really a concept of an enterprise command center with physical hubs throughout the enterprise. So any part of our virtual care hubs can step up and take over. They have to know the protocols, they have to know the software, they have to know how to interact with patients. And then ultimately partnering with other redundancy measures like medically home, saying, hey, if everything went down in Mayo, could Boston step up and be a hub for a few hours and make sure we send the paramedics and others to our patients to be looked at while we get our systems up and going? So it's being a part of an enterprise and separated by geography and time zones is very difficult. So we have a multi-layered plan on how to address different disasters and then channeling that through a command center, which is physical in nature, but can be brought into a virtual sense or moved if a disaster happens to the command center itself.
Great, thank you.
Sure.
Kevin and Sarah, I don't know if you wanted to add more. I know you touched on this a little bit, Kevin.
Sure, I was going to chime in just a little bit more, just to talk a little bit more about the structure. So one of the advantages of being a system, and I would say especially over the last 2 to 3 years, we've really worked hard to really work as an integrated healthcare system. And we made the decision to centralize all of our emergency operations planning and the core team. So for example, Sarah is part of the Mass General Brigham emergency operations team. And then locally within MGB Healthcare at Home, we work closely with Sarah. She's our point of contact to help coordinate. So it's really great to have at the system level. We have the HIC structure at the system level, as well as the Emergency Operations Center at the system level. And then of course we have that at the local level with our administrator on call structure, as well as the local HIC structure and how that all docks in together. And as I mentioned before, having the advantage of having traditional home care, which has a census of 4,000 patients a day, pretty big program, having a pretty robust emergency operations plan that's already been in place to be able to leverage that as well as the existing AMCs has been a huge, huge advantage.
That's a great point. So it's not only the hospital's emergency protocols, but if you have a home health agency or some other home-based program, maybe a hospice or something, you might be able to kind of utilize those protocols.
Yeah, and just to expand a little bit further, just to give an example. So if it was a digital IS related event, which I'm sure several folks have experienced over the last couple of years, we recently actually just had one. There's a whole structure in place that is a system-wide approach to managing that digital/IS solution. So it's just really great that it's centrally coordinated. And just as an example, once it was initially identified, the communication comes out centrally, the emergency team is activated, and there are representatives from the home hospital, home care, and others, and all the other entities in our system that hop on a call, situational awareness, and then we can really react pretty quickly. And then we know what to do in the initial, I would say 1 to 2 hours of the event. And then we continue to touch base and implement the specific procedures, or we're able to give folks advance notice or give them some initial direction as the rest of the event rolls out. But using that digital event as an example, it's very well orchestrated and coordinated.
Great, thank you. And we'll turn to our last question before we open it up to the audience questions. So this question is, how do federal, state, and or local emergency policies affect your hospital at home program emergency policies? And I think we're going to start with Scott this time. Is there anything local, federal, or state that affects you?
Well, in rural Kentucky, we don't necessarily have the same infrastructure for emergency response as the urban areas would. So honestly, the initial response is our hospital system, local county EMS, local law enforcement, things of that nature have their protocols in place that we would rely upon. We would basically initiate our own response and coordinate with local, with state and federal, in that area, beyond your local capacity, you're looking at National Guard, basically something like that. And so when they have established protocols in place, then it's a coordinated effort amongst the hospital system that we're in with our own policies, kind of merging with what they may have, but it may take some time. They don't have them at a minute's notice in our rural areas. So initiating the response based on our own policies, taking all the help we can get, so to speak, once it arrives. And then, then it's just not overlapping and stepping over each other. We're coordinating disaster relief in this location. What can you do to support that from the rest of the state? When the aid does come, where's that supply chain lie? Who takes ownership of that? And then how do we dispense what we do have? And we've utilized everything from utility vehicles to, our EMS, to when the National Guard arrives, it's coordinating. I've been there, you go here, and what can we do to help each other? So as we learn, we're still a new program too. So as we learn more, and I'm learning from this group as well, then we will fine tune those. But in limited resource areas, in rural areas, we initiate it and then coordinate the help that is offered at that point.
Thank you. I think we're going to have Mike and Vanessa respond to this as well.
Yeah, I'll take this one. Building off of what Scott said, there's not a lot of local or state policies in Wisconsin, Arizona, or Florida really that are specific to hospital at home programs and emergency preparedness, but our approach has always been to follow DEMA guidelines for acute care hospitals and to bend those kind of guidelines to meet ACH to the best of our ability. So similar to the hospital leaders, we have ACH administrators who go through the training to understand how the incident command systems function, and we work with safety each year to ensure that we're prepared to handle these emergent situations. Our command center in Florida is connected to the hospital's backup generator, so we have a low likelihood of ever losing electricity. And then we also installed redundant outside like ISPs, which leverages modems so that we have multiple connections for internet. And so we've done our best to ensure that we don't have an unexpected outage. But really what we've been consistently trying to do is to embed advanced care at home into existing frameworks that are already stood up within the hospital, just because there's not a ton of guidance or policies that we can follow in the event of natural disasters. The one thing that I guess has been like our guidepost is it seems pretty clear that we need to ensure that we have immediate on-demand connection to our patients, and that we need to be able to respond within 30 minutes in any kind of emergency situation. And so I would say our emergency preparedness guidelines are really focused and built around that to make sure that if there's ever a situation where that would come into question, we tend to err on the side of caution and make sure that our patients are safe and plan for those downtimes so we know what to do in the event something like that would have to happen.
Thanks, Vanessa. So we have some great questions from the audience that we're going to turn to now for about 10 minutes. Again, any audience members, please put them in the Q&A, and some we have started answering and answered live, but I want to go through them anyways. Some of those ones again, but I'll just start here at the top. So one question, anyone can help answer. If you're stocking the patient's house, how do you manage medications that may be subject to change? We have also run into issues dispensing for days far into the future. Anyone sending, like, if a storm's going to happen or weather's going to happen, that you're sending more than your usual amount to the patient's home, like maybe 3 days supply of something?
So I can use an example during a recent severe weather event or severe cold. We did look at that and looked at what amount of supplies would be needed, a little bit longer than usual, and that would include the medication piece. So we did incorporate that piece. The other part, like Sarah mentioned too, is if there were certain medications that required refrigeration and there was a power related issue, we'd look at those items as well. For the most part though, our geography is, I would say, a pretty manageable geography. It sounds like very different from what some of the others on the panel are experiencing with long distances. So we do have that advantage of, for the most part, being in a really good position to be able to get supplies and the appropriate equipment, medications to the patients.
Another question here is about the clinical teams. So I think we talked about, Scott, you work with EMS to be able to get there, but how about your normal like your x-ray company or the couriers or your nurses? How do you consider plans to make sure those team members are available or communicate with them if there's a disaster?
Yeah, so we have the RNs, we have a van that we have for routine transport if we need to get back and forth for imaging. If they have the ability to for access to their home. We can bring them back for imaging or, you know, an outpatient procedure, or, you know, maybe have, to your point about medication, restock supplies. And then, you know, ideally, you know, a community paramedicine program would be an ideal situation like that to rely upon. We don't have that in our area, but we do have that agreement with EMS in terms of if there is a call that they need, they can go assess, say, for instance, similar to if someone called out for a blood sugar concern on a routine 911 call, and they can say, all right, we've fixed your blood sugar, and people sign out, you know. So it's the same concept of being able to treat certain conditions that we have allowed them or requested them to assess. And if they have to do more than they're able to do, then they can bring the patient on back. But, you know, planning ahead in terms of, you know, what transportation can we provide outside of EMS, and we've done that. Of course, then you got to have contingencies. What the van goes down, you know, what other backup plan do you have? But using some of the community resources that we have, limited, but it's enough there that we feel confident if we had to get, you know, supplies or transportation, that we could make that arrangement.
Yeah, and just to add to that, very similar. So we have our mobile integrated health paramedic team that's part of our home hospital program. We now have several four-wheel drive vehicles, so they would have access to the patients, or do have access to the patients. And very similar to what Scott described, is that if there was an urgent or emergent type need, then they would be able to get what they needed to the patient. Regarding staff too, the other thing, going back to the whole question earlier about helping folks to be prepared. So what we also do is we communicate to all of our direct care providers and really highlight a few things. One, stay informed. So we refer them to the severe weather policy and all the different steps, what to do, other resources that are available, including our local emergency management agency. So MEMA, the Mass Emergency Management Agency. We even go as far as highlighting even tips of what they should be wearing, how to make sure that they're caring for their vehicles, and tips for winter driving, just as an example for a severe storm, if it was in the winter, or severe rainstorm. So we try to look at ways that the staff can be prepared ahead of time and take the appropriate steps to be able to get to the patient's home safely.
Thank you. There's kind of a different question here, kind of flips the emergency. So are any of your programs included in your institution's disaster response as an asset to increase capacity? Examples of the mass casualty event and the need to dramatically increase capacity in the brick and mortar building, and potentially shifting patients to the home hospital.
So I'll jump in there. Give the flood for an example. The first 48 hours was basically just trauma evaluations, and the ED was, you know, inundated from those mild injuries to significant injury. After the initial trauma of the swiftwater rescues, then it became the chronic disease management. Now you're out of medication, or, you know, your situation flared up, and so then and you had no home to stay in, right? So then it became a critical, you know, census for us. And so that would be a great opportunity for us to expand capacity, right? Assuming that we have a safe home environment. But it does allow us to flex a little bit and offload the burden of the ED, whether, you know, you don't want to have to board in the ED longer than you absolutely have to. And so we specifically chose diagnoses to treat at home, and this can expand, but again, as a new program, we want to make sure we got it right. So being able to use that as a flex capacity for, you know, surge is a great option for us. And frankly, we hope to take situations that I'm learning as we go, and develop better programs to make sure that happens. So yes, it is an ideal situation in a certain situation like that.
Yeah, I agree. We've talked about this. It really comes down to resources and whether or not you can flex up to 20, 30, 40 patients quickly to open up your space. That may be possible in some programs. It may not be possible with the resources available. But something else we've talked about is actually sharing resources, or if there's a disaster, you know, in a tornado in Oklahoma, could other hospital home programs throughout the country virtually chime in and help take over some of the workload from the physician and nursing standpoint. Use the local resources, but don't put that all on the institution that's there in Oklahoma, but actually all of us step up and take a bite as opposed to sending people there, virtually connect and take over as part of a national response. That's something I think as these programs get more mature and we start to get more integrated with each other, sharing supply chains, sharing technology, sharing platforms, that will be capable in the future of a national response.
Yeah, and just to add, I mean, I think it's a really excellent question and very similar so far. How we have incorporated it is part of our capacity management plan. It is one of the key strategies to really help on a day-to-day basis to create additional capacity for our patients in the home setting, and then to be able to create additional capacity in all of our acute care and community hospitals. But we have not formally linked it to our emergency operations plan. That's a really great idea, and we'll definitely bring that back to the team.
There's some great questions here. We're not going to be able to get to them all. I really appreciate that the participants are answering them in real time. I'm just going to bring up one more as our last question, because I think it might be a little bit controversial. Does anyone have any thoughts on plans to proactively move patients to another location, not the hospital, in preparation for a weather event? I see that, Mike, you answered this in real time, but I don't know if others have other thoughts on that, moving them to a hotel that's clearly out of the danger area, or moving them to, a center where you can set up ability to take care of them.
So I think the concept really of caring for someone in their own personal environment could be modified to any environment, so long as certain criteria is met for safety and quality as well. So I think, yes, I think that, when forced with no other option, you create the option. If the technology is there and the capacity is there, yeah, I think you could set it up anywhere, if the situation required it.
Yeah, I think the question comes down to, again, is this multiple patients going multiple different places? What's allowed by rules and regulations? If it's all one place, then it's just another hospital, technically. I guess, you could make a medical community or, use a nursing home or gym or something else, obviously, for a temporary basis, which would work out. You just have to make sure that the same experience and quality of care travels through. But I think it's a neat concept to think of. Again, goes back to, if different areas are affected by different things and different disasters, how we help each other or use resources in the community to make sure the continuity of care of our patients is continued. So I think that's an exciting thing to talk about.
Well, I wanted to thank everyone. We've had some great discussion here, some really great questions. I have just a couple slides I want to do as closing remarks here to remind everyone we have a research a project on caregivers coming soon. And next slide. We've put this up a couple times. The Hospital at Home Users Group has 2 projects going on. The first is a program standard survey. If you go on and you use this QR code here, it's just right at this point, just saying, picking a point person for your group who will later on get a program standard survey. That's what you're doing right now by doing this QR code. We just want to make sure we have 1 point person from each of the Hospital at Home groups out there. And the program standard survey later on is a survey about how you operate your program. And then next is the minimum data set survey. Again, if you go on and do this QR code right now, it's again to be pointing a point person for this. This is something that's going to be a little bit more involved because this is getting patient level data to really have a good data set of hospital at home programs across the country. But we would really encourage you at this point to just go on and get your point person, do the QR codes, go to these websites and just appoint that at this time. Reminder about the annual meeting. It's gonna be super exciting. It's Lollapalooza, but Hospital at Home Palooza now. Very excited about this multi-day event. Then, next slide is just remember all of our wonderful webinars are recorded. You can go and find them again afterwards. Just remember about our websites. And Thank you again to our sponsors and all our attendees and the John A. Hartford Foundation and the American Academy of Home Care Medicine. So thank you so much.